Jesse Chason with Lisa Blanchard as the host of Airing Addiction.
I share often my journey started on this campus. Got sober as a client here, just like you.
I really do see phenomenal change.
Always hope. I've seen situations that on the surface look impossible become possible.
Doing this podcast is to share those recovery stories, be honest about what the challenges are and have some real conversations, but kind of share that out on the airwaves.
A brand new year with wonderful, impactful, important guests in the field. We were just talking before we hit record of the eclectic mix of guests that we've had on here, from professionals in the field as we do today to people that share their lived experience and everywhere in between. And I think this podcast particularly will be interesting to people who are either kicking this recovery idea around and not really knowing too much about it, or friends and family, I should say both, and friends and family of those in recovery and seeking recovery. Because so often, I know I find, and we've talked on here before, Lisa, about just the black box of treatment that recovery can be. And unless somebody's intimately involved themselves or with their loved ones, you know, there can be a lot of misinformation or confusion about what treatment is and all the different modalities of treatment and the whys and the science behind it. So we have a very important guest in that field today, and very impactful guest. And good morning, Lisa. I'll turn it over to you to introduce who we have today.
Good morning and Happy New Year, Jesse and James and all of our listeners. I'm really excited about this episode today. I had the opportunity to meet our guest at a statewide peer recovery meeting and was really struck by the research and science that really, for me, confirms what I already think, right? As a clinician, as somebody who works with those working towards and in recovery for the last 25 years, it really is just kind of affirming what we think happens, and really supports the idea that there's kind of a difference a little bit between kind of, entering treatment and what does long-term recovery look like, and what are the things that you need to support long-term recovery. And we want to support folks with treatment, right? Low barrier access, medications. Everybody who knows me knows that I am a huge fan of offering immediate access to medications and harm reduction. But then what, right? Once we get folks stabilized, then what? How do we help folks really, live the lives that they would like to live? So I'm really, really excited today to have Dr. Corrie Vilsaint on. She's the Associate Director of Recovery Health Equity at the MGH Recovery Research Institute and an instructor at Harvard Medical School. Dr. Vilsaint is a community psychologist and an international speaker, so you all are in for a treat today. Her research endeavors have focused on reducing recovery-related discrimination, building recovery capital, which I'd love to talk a little bit more about what recovery capital is today, and the effectiveness of recovery support services. So welcome, Dr. Corrie Vilsaint. We're so excited to have you here on the podcast. And I wonder if a great way for us to just start the conversation is for you to tell us a little bit about, how did you get here? How did you get interested in, recovery as a research area and recovery support and what that looks like and how effective it is? If you want to give us just a little bit of that background to kick us off, that would be great.
Sure, absolutely. I'd say part of that is kind of a leap of faith that has to happen along the way. It becomes pretty clear early on that there are certainly options regarding the field of treatment became well established. There's the field of prevention was taking hold scientifically as well. But I was trained as a community psychologist, and so I was not clinically trained. I didn't know that I want to go the prevention route. So it's kind of a leap of faith. And then as I progressed and got out there, it turns out recovery has a seat at the table. And so, by being able to link up with certain people like the Recovery Research Institute and John Kelly, I've been able to participate in developing this field, which has really taken a hold. You can even see it in, let's say, our federal offices. Now they have offices of recovery, right? And so it's really becoming part of the infrastructure, and it's allowing for people who are both who are trained professionally, but also have expertise and lived experience to have a seat at the table and to how we proceed and how we build this infrastructure. And so I'd say that's about how I ended up here.
That's just so fantastic. And I guess I had the opportunity to hear a presentation for you, so I know a little bit about some of the work that you've done. But some of the things that I think were really helpful to recognize is that like Jesse said, treatment can be a black box, but I also really feel like recovery for individuals who have not either had to seek or are in recovery. People think it's just the cessation of using substances, and then you stop that, and then you're done, and then we're good, right? And then life returns to normal. And we in the recovery field know that that's not true, but so many people don't really understand what that looks like and what the difference is between kind of acute treatment episodes, what the purpose of that is, and what does long-term recovery look like? And I wondered if you wouldn't mind talking a little bit about that difference between treatment and recovery.
Oh, I would love to. I think that's a good place to start it. Let's make some distinctions between what are recovery support services compared to what people think is traditional treatment for substance use disorders. Recovery, in fact, recovery community centers, there's a growing recovery support service. They're a class of recovery support service. And I would say that these recovery support services compared to treatment can be distinguished by a number of important factors. The first one is the providers. Okay, so treatment is delivered by clinicians, while recovery support services are delivered by peers. Peers can be credentialed, they have lived experience as part of their expertise, and so they are provided by different providers. The location is actually very different. Treatment is delivered in healthcare settings, while recovery support services are delivered in the community. This is critical for reaching certain populations. You have to go into the community where they're at and not always expect them to make the trek into the hospital for care. This has huge health equity implications. Additionally, the time frame is different between healthcare provision and versus recovery support services. Treatment is often time limited and can be short, while recovery support services are designed to be long term. And, importantly, the goals are different. Okay, we have our treatment providers who are here to address symptomology, reduce pathology, while our recovery support specialists are here to build recovery capital, is one of the things that they are going to specialize in. And so I think those are some of the most important distinctions that we could make right off the bat between healthcare and treatment versus recovery support services.
And it might be helpful for our listeners to have us maybe define what recovery capital is. What would
yeah, absolutely. Recovery capital is this kind of emerging international construct in the addiction field. It represents the sum total strength-based resources, both internal and external, needed to initiate and sustain recovery. Recovery capital helps to mitigate the biopsychosocial stressors associated with adaptation to abstinence. And it stands in stark contrast and complements deficit-based approaches that we're used to taking stock of pathology problems, and maybe people start to feel powerless. So we also now want to take stock of what is working, what is adaptive, as opposed to only maladaptive. And so it's a nice complement to the frameworks that we come out of.
I love that, because as a clinician, and I'm a licensed mental health counselor, so this is what I do, right? And I have a role, but it's it's so often kind of recognized that, yes, I'm trying to reduce the impact of whatever diagnosis somebody's presenting to me, whatever symptoms they're presenting, whatever's getting in the way, whatever's bringing them to me today. But I want to do that not in a vacuum, right? Not in a place of, all right, so the goal is to reduce your depression or anxiety or to reduce your substance use, and then we're fine. It's where do I start from is that strength-based approach. Right? What do you already have and what can we build on that can really support you in a holistic way instead of just reducing symptoms, right? And really taking that strength-based approach.
That's great. And that might kind of lead us into discussing maybe the history or the origin story of why these recovery support services have even emerged. There are really historical reasons as well as more recent scientific reasons as to why they have emerged. Substance use disorder services traditionally have been very separate from general health care and even mental health care at times. For example, we know that like AA was founded in the early 1900s because providers did not attend to substance use disorders. Even in the 70s, addiction was viewed as a social problem dealt with civil and criminal justice. So the existing healthcare system at that time was neither trained to nor really especially eager to accept patients with substance use disorders. And this is why grassroots community-based services, the first two on the scene were recovery housing and 12-step meetings that emerged out of an unrecognized need from the healthcare system. And as healthcare did start to come online, they reinforced the notion that substance use disorders were different from other medical conditions. Healthcare failed to recognize health conditions that were related to substance use disorders. And they segregated treatment out of mainstream healthcare. This was because we relied on stigma, stereotypes, and moralistic frameworks, which led to discriminatory decision-making as opposed to scientific or medical frameworks. We still, to this day, have very enduring impediments to quality of care that this has created. This is why patients who use methadone, which is an effective medication to treat opioid use disorder and a frontline treatment, have to travel to a certified opioid center as opposed to getting their medications dispensed at a pharmacy. This is why we've developed sometimes a less formalized language in our field, and we refer to tests as being dirty or clean as opposed to positive or negative. This was because this culture was segregated out of healthcare. Sometimes I hear practitioners say that a patient can't be trusted as opposed to maybe thinking that saying a patient is symptomatic or experiencing recurrence of use. Okay, and so this came out of that history. Now, the recovery science is another thing to consider regarding why recovery support services emerged. And so we started to develop a science around these things, and new information came about. And now we know that historically, we did approach substance use disorders with a very episodic approach, meaning medical detoxification, stabilization, some type of brief episodic treatment. In fact, even our clinical trials averaged only about 12 weeks. But today, we know that it takes about 5 years of continuous sobriety before the risk of a recurrence drops below 15%. Why 15%? Because this is when you're no more likely to have a substance use disorder than somebody in the general population. And so we've given this elevated risk timeframe, we've started to approach public health infrastructure to address this from a continuing care paradigm or a recovery management approach. The goal is to map services onto what we know about the duration of course of illness and recovery, and more importantly, to accelerate those timeframes. And recovery support services play a critical role in supporting this long-term recovery. In fact, they are listed in the U.S. General Surgeon's Report on Alcohol, Drugs, and Health, as well as the National Drug Control Strategy.
Thank you so much, Dr. Corrie, for all you've done in the field and all you continue to do. I'm sitting here just soaking it all in and having the PowerPoint with the data right next to me. And this podcast can be 5 hours long with all the questions I have about it, because this really legitimizes and structures something that I've personally witnessed, and thousands of other people like me have personally witnessed, that recovery capital that we talked about is so important in long-term, not just away from substances, but rebuilding life. As we all know on the podcast, and people who are listening to us, that recovery is so much more than just cessation of substances. It's putting down the substance and asking ourselves, now what? So I guess my question here, one of my many questions here, Dr. Corrie, is how does recovery support services help in developing that recovery capital? You mentioned that after 5 years, the chance of reoccurrence of substance use disorder drops to that of a person without one in the beginning. How does recovery support services help that person come in and develop that recovery capital so that they can get to that 5-year mark?
Thank you. That's, I think, exactly what the next question should be. There's a number of types of recovery support services, I think, that we should highlight for everybody. We know now that people are going to recovery high schools, collegiate recovery programs have come on board. We know there is digital recovery support services, there's smart apps, virtual reality, there's recovery housing, there's peer coaches, and there's also something I'll talk a little bit about called these peer recovery support centers, these recovery community centers. These are really like an emerging third tier on the continuum of care. They serve as a brick and mortar location in the community that provides walk-in services. I call them the Amazon shopping of recovery, because you can access, they vary by site, but you can have access to recreational, social activities with sober friends. Recovery coaches are often trained and launched from these locations. You can have access to technology, internet, resume, building services. There are opportunities to give back to the community, health, exercise, and nutrition programs, linkages to housing assistance, health insurance education, Narcan training, and distribution. These are all part of the building blocks that people need to get their foot back in the door to life, while our providers are addressing symptomology and pathology. These are those building blocks that we need to not only give access to, so people can rebuild their lives.
And so some of the things that I was really struck on your research is, and I love the peer recovery support centers. Spectrum, provides, actually, we're about to open our 5th peer recovery support center in Massachusetts in Southbridge. We were one of the first to open in the state of Massachusetts. And so I'm really excited and proud of that. But one of the things that really struck me is some of the research that you're starting to do about what the impact specifically of these centers is and how it starts to improve the quality of life faster, right? For folks in recovery than if they hadn't been going to a center.
That's right. We know it takes about 15 years in recovery before quality of life returns to the same levels of the general population. That's too long. Okay. So imagine if we could accelerate that to a fraction of the time, let's say 5 years. This is what we believe recovery community centers are doing. And so the reason that we have this is a very reasonable hypothesis is because we've got one study that we did in the national recovery study. And that's where we learned that it takes 15 years before quality of life returned to the general population in the US. But our studies in peer recovery community centers are showing that they're hitting that same level of quality of life at 5 years in recovery. Okay, that tells us the hypothesis is peer recovery community centers are accelerating quality of life. And we continue to dig down into that science and tear that apart. But that's one of the main findings that we are putting together here. And it is all about shortening these time frames around what we now identify as a chronic ongoing health illness. So, and that's part of what the recovery science can bring to bear when applied to these recovery support services.
And
Go ahead, Jesse.
Sorry, Lisa, I just have so much I want to ask and talk about, because Dr. Corrie, this is really hitting home for me as somebody, I've shared on the podcast before. I've been in recovery for 14 years, and I'm thinking of these numbers we're throwing out here. And,
Oh my.
if I had to wait another year for my quality of life to get to any reasonable, livable quality, Lisa would have a different co-host here.
Wow.
I sit here as proof positive that this works, because I've had the blessing and the fortune of experiencing both inpatient long-term treatment with Spectrum. And then you'll love this, Dr. Corrie. Every week we would go to one of Spectrum's peer recovery centers. So we were getting both ends of the spectrum, no pun intended,
Wow.
of different ways and modalities of treatment. And as somebody who was completely naive and new to all this, as I was back then, it struck me almost immediately of the different ways that we interacted. Where I'm living in a recovery house in a modified therapeutic community, and there's structure and there's rigid rules, and my whole day is planned for me, versus when I go to the peer recovery center, this one particularly in Marlboro. And I went there, and I remember there was a ping pong table, there was an NA meeting, and there was lots of food. And it helped me really just, unstructured time sometimes, I believe, benefits those in recovery, because if I'm told what to do every hour of every day, yeah, I'll stay in recovery as long as someone else is telling me what to do. But when I went to those peer recovery centers, I was given that freedom to sort of find my own path. And yeah, maybe I ended up at the meeting, maybe I ended up playing ping pong, maybe we just fellowshipped and ate. But all three of those and many more resources were available. So I think we should put the Amazon shopping of recovery right on the new peer recovery center in Southbridge, because really that's, the threshold to, that freedom, if you will. And I can't wait to tear apart this research study that you had highlighted. And I suggest for anyone listening that's interested to dig deeper on that, because this, again, proves positive, like you said, Dr. Corrie, that this hypothesis not only works, but it's coming true in communities. So I guess my question here, if I may, would be, what barriers, as you see them, do we still have to overcome to get this vital resource that's now proven to help into the communities that we need them to be in?
Yeah, that's a great question, because this is a relatively, I would say, new resource in our field. We're here in Massachusetts and kind of spoiled rotten. We have more here than it's possible, maybe. We're definitely at the top one or two states, if not the top state in terms of the prevalence of these recovery community centers. I would say one of the biggest things that I would be useful in spreading the good news about this resource is going to be able to translate what we know is the lived experience as testimony that you provide, and have the science to back it, so that people can see proof positive, the evidence of these services, and that we have more options than trained clinicians as a pathway, a useful and effective pathway to recovery. So
That's
I think
fantastic. I would add just a little bit to build on what Jesse said, and that ties back to some of what you said earlier in the podcast, Dr. Corrie, is that Jesse described his experience, and I run modified therapeutic communities still, right? Like, I think that there's some real benefit to teaching some of that structure and skill, but there is inherently, as a treatment provider, when we are structuring everything for someone, that gives the message that there's no trust that you could do it on your own. And so the real difference between kind of structured treatment and here's what you need to do, here's the path you need to follow, and just show up at the center and take part in whatever fits you, right? Do you want to play ping pong today? Do you want to go to a meeting? Do you want to join this committee? Do you what do you need support with? What do you need help with? Really puts that person back in the driver's seat of their own life, right? They really get to do this in a very self-directed way versus here is your treatment plan. Here is what we are going to tell you that you need to do. Although, we do our best to make sure that those treatment plans are are direct patient-centered and all of those things. There's still always that element of, the treatment provider is the expert. They should be telling me what to do versus I'm the expert kind of in my own life.
That's right. And you know what? We know that treatment works. The science is clear on exactly kind of the effect sizes that we're going to get and that we're going to have an increased likelihood of getting into remission because of treatment. But we've also kind of changed the approach of our studies so that not only do we embrace those clinical trials that lead to that, but we're also going to use epidemiological studies because we're going to start to understand pathways to recovery that people use, and that treatment is one pathway. But we also have studies now like the National Recovery Study, which has showed us that amongst people who have resolved a problem with alcohol and other drugs, how many of them are using these recovery support services? That study is a number of years old and was showing about at least 700,000 people have used recovery community centers as part of their pathway. And that number has only grown because that study, I think we did that 5 years ago at this point. The idea of these recovery support services as well is that of course, they need to be effective, and we will take care of that with the science and determining what we can get from them. But we need different ways of attracting people into pathways of recovery. That's what we're trying to diversify and attract people of not only even different age groups, right? We're starting to see centers that are focusing on exercise, health, and wellness. This has the potential to capture maybe a different or include an age group that we weren't capturing in 12-step meetings. Right. And then that maybe they don't want to be there. Even if it is useful, they might not want to be there. So what else can we figure out and really drill down into? This service might increase your likelihood of remission by 20%. Treatment might increase your likelihood by 30%. Recovery housing about 35%. And really nail down those numbers to provide people with pathways to recovery as opposed to prescriptions only. Right? Prescriptive approaches to recovery only, because we've got to attract and engage. We got to be able to attract and engage.
Right. If somebody doesn't make it in the door, it doesn't matter what the evidence base is, right? So we need to have those options. And one of the things that really strikes me is that, and, I'm a clinician, so I do a lot of, DBT and clinician work. So I love the concept of both and I think sometimes in the recovery space, in the evidence space, I just read an article this morning from Yale that pretty much said for opioid use, if you're not providing medications, it's actually harming people, right? And I don't think that that's not true, right? I believe very strongly that treatment is effective, that medications should be the frontline treatment. It should be automatic and low barrier, right? We know that there's evidence base for that, and that recovery support services are evidence based. Right? Like it doesn't have to be an either or, and we don't have to be competing. And I love the idea that it sounded like you were describing of let's get all of the evidence together and combine those percentages, right? Like what can we do to build on, here's how treatment will support you and will help you. And here's how these support services will help you. I mean, I think we've been doing this in other areas of healthcare for a while. I've walked pathways with close friends who have gone through cancer treatment, right? And so then there's here's your surgery and medication options. Here's the evidence base for it. Here's all the other things that you also should be doing, right? That will support the impact and likelihood of remission in the future. And that's a lot of the holistic and nutrition and support and peer support, right? Like it's not that different from what we're looking at. And by saying all of these other things are helpful, we're not saying that treatment isn't, right? Like we're saying
That's exactly right. And we need to start to shape the evidence base in such a way that we can answer those types of questions. And so it's become clear to us that medications are part of it, like, for example, a frontline treatment for opioid use disorder. And you'll certainly hear abstinence-based approaches kill people, maybe to our current knowledge. But I will tell you something else. The day we do a trial of medications alongside recovery housing, I have every reason to believe you're going to have, that trial hasn't happened. When we do a trial of medication over here and trial of recovery housing over here, we don't have the scientific language between the two of them. I think you're going to see that when those are trialed against, you're going to have two pathways to recovery. Maybe medication might have a little bigger effect, maybe recovery housing, but they're going to be two evidence-based pathways to recovery is what's going to happen. You know, we've trialed recovery housing for opioid use disorder. We know that following medical detoxification, the standard of care would be to give a patient a list of resources in the community. Here's some providers. Good luck. And we know that they're going to have abstinence rates at 6 months of about very low, about 13% will be free of opioids and cocaine at 6 months. But if you send them to recovery housing, randomized controlled trials have shown that numbers goes up to 37%. Okay. And then if you combine a specific type of treatment in recovery housing, you're going to boost it to 50%. Trials like that show us, one, we still need to trial with medications because that's a frontline treatment and needs to be on the stage. And second, it also tells us those were two pathways to recovery there. And one was not a pathway to recovery, which was handing a list of resources to people after detoxification. That was not an evidence-based pathway to recovery, but recovery housing was. And when you throw in treatment, it only got better. So choose from your pathways. But yeah, the science base is not fully developed, right? So we can only speak to it as to what it is, but it needs to continue to grow. There is an entire ecosystem of recovery support services that need to be studied the same way we lead out a great map of treatment and inclusive of treatment so we can identify pathways for that people will latch onto and understand the likelihood of getting into recovery if they approach that pathway.
And the more we can build these bridges, and I think starting with that scientific language and kind of getting everybody talking the same language instead of choosing teams per se, right? The more you can say, well, you know, maybe you could do medication and residential and then transition to a recovery home. Maybe you could do medication and a recovery home, right? Like housing. Maybe we could do, you know, here are all of the options and you can do them all at the same time if that works for you, right? And so that requires a lot of reducing stigma about medications, reducing stigma about addiction, and reducing kind of stigma about which pathway you choose. And so one of the things that I really appreciate about the peer recovery support centers, you know, at least those that we have in Massachusetts, is the really strong, you know, understanding in the centers of multiple pathways, right? So even if somebody who's in the center took one pathway, it's not, I did it this way, you need to do it this way. It's really supporting that all pathways to recovery are recovery, and you're in recovery when you say you are.
Right. Boy, the stigma point you hit on is, you know, that's a big one. That's a big one. And stigma reduction, we do know of certain things that are empirically supported in stigma reduction. One of the easiest ones that we can grab is going to be the language that we use right off the bat. Anybody can adopt it. Okay, so we now have evidence-based studies showing us that when we refer to a substance use disorder as opposed to substance abuse, we know that this actually leads to clinicians having more punitive attitudes towards people with substance use disorders and the general population. It is a measurable effect size when we adopt languages, and there's entire language guides out there varying to degrees in the evidence base, but stuff like that, the evidence is strong. It's a very quick tool that we can use. There's even been evidence in the field of harm reduction, talking about overdose prevention sites, and the way that actually garners public support, just depending on how you talk about it. So language is one of the quickest things that we can do to reduce stigma in this field, because stigma is absolutely a barrier. In fact, there was a international study of many countries that showed addiction was the number one most stigmatized condition, ahead of being a criminal, ahead of being HIV positive. Number one was drug addiction. So you have to understand we are dealing with the most stigmatized condition in the world, and it has affected every facet. Our policies, our language, our approaches, the way the media deals with addiction. And so part of that, we need to do, that kind of literacy. We need to engage in a literacy movement around this as well, and kind of re-educate ourselves about what we've been taught about addiction, because stigma is absolutely a barrier.
I'm in such support of that. In fact, one of the very first, I think 2.5 years ago now, it's about how long I've been doing this podcast. We did an entire episode on language because it's just so important. We had Julie Burns from the RISE Foundation, and we had Dr. Miriam Kamaromi from the Graken Center at Boston Medical Center. And we literally just spent the whole podcast talking about language and how it's shifted and what that impact is. But we still hear it, right? I still hear individuals in the field use the word abuse, and I jump back and I try to, be gentle in my, intervention, but it really does. I love that you're saying it has measurable impact. I love how, you're able to kind of take all the things that I know and then use research terms to say that that's actually really true, right? That the words that we use do matter. In fact, we at Spectrum and New England Recovery Center have everybody take, we adopted the Boston Medical Center Words Matter pledge. And so every staff person, when they start, has to take every clinician has to take the Words Matter pledge.
Wow.
Starting with us.
Yes.
And Dr. Corrie, I would also add too to what you had just said about stigma and addiction being the most stigmatized in the world. How many of our patients, and certainly I can identify with this, I told my story on the podcast long before I was a co-host with Lisa. How many of our patients or people coming into recovery have more than one stigmatized condition? You talked about being a criminal or being HIV positive, or all these barriers, not only to treatment, but barriers to internal self-esteem or dictating the way that I think about myself or how I even identify. Because I don't look like the area or the things that I came from, but how often do people stay in that same area? And we know from other studies, over generations, we see the same crimes and the same family destruction really happen time and time again, because people are just really, I believe, beating themselves up over all these stigmatized conditions. And here we are, and this is, not only validating to the work that Spectrum Health Systems has been doing long before I came along, and hopefully long after I'm gone, but also to the people that are listening that are in recovery and knowing that we're more than our disorder, we're more than our diagnosis. One of the things that Maureen Cavanaugh, who founded Fast Magnolia Family Support Group, had us do when she trained us all in that approach before Spectrum launched the Fast Magnolia Family Support Group, which, Lisa, 2 years now, something like that has been going on. She had us write down the 5 things that we identify as in our lives, and then cross one out, and then talk about what it felt like to have that crossed out. And that was a very eye-opening experience, because it's, again, dealing with the internal self-esteem. If I don't feel good about myself, then, it doesn't matter how low the barrier is to treatment, I'm not going to feel worthy enough or able enough or whatever enough to engage. So, just thank you so much for all your work that you've been doing and continue to do. And I look forward to seeing where we are, in another 5 years from now with the research and really putting, like you have been said numerous times here, marrying the science and the data with these systems that are already in place to really put percentages on, all the options, so that we can then better treat the people coming in and having a real concrete number of, if you choose this pathway, this is the percentage that the data shows.
That's right. That's right. I think that's the best way that science could offer to help better communicate with people who are walking in the door. It's funny, sometimes in our field, we might only see ourselves as a clinician or only as a peer provider, but the people coming in the door, they see us all as addiction specialists. And so we need to be able to articulate the likelihood of the pathways to recovery that are actually out there, and so I do think that's a nice point that we absolutely should be heading towards, and you articulated very well stigma, how it has affected people, the utility of addressing that, and to just take it a step further, the one of the problems with being part of a stigmatized group is that they are now vulnerable to discrimination. So that's the behavior that follows when you are part of a stigmatized group. I wrote a study on recovery-related discrimination, actually, and I just wanted to know the prevalence by which it was occurring to people who, even after resolving a problem with alcohol or other drugs, and I was finding that it kind of grouped itself into what I called micro and macro level discriminations. It was like personal insults and slights. And then there was stuff that was related to policy and organizational things that were keeping them from getting their foot in the door, despite the fact that they were in recovery. And I knew that this was a national study of people in recovery. It was about nearly 19% of them saying they felt like they had been treated unfairly by the police because they knew about their history with alcohol or other drugs. 15% reported in this country, and people in recovery reported receiving inadequate medical treatment because they knew about their history. 11% said insurance would still not cover their medical cost. 16% said they could not get a job because of their history. 12% were denied a loan because of their history. We know this was a federal policy, and that if you were caught with drugs as a student, you were not allowed federal aid. 9% were denied housing. We know that having drugs on you was one of, and sometimes the only, crime that kept you out of housing and that kept you out of loans. That's how stigmatized this was. You could commit murder, embezzlement, and still retain your rights to those services. Okay. And so this is what we called recovery-related discrimination. 8% said they were denied nutritional assistance because they were aware of their history. They're aware of their history. And then, there was a lot of psychological things happening too. 47% said that people believed that they were likely to relapse. 20% said people told them they looked like an alcoholic or an addict. 28% said they were ignored by somebody because they knew about their history with alcohol or other drugs. This generation does not consider that just a consequence of your substance use. This generation considers that discrimination.
So I know we're kind of getting to the end here. So I'd love to, have you share anything that you think we might have missed. But one of the points I'd like to make, which honestly could be a whole nother podcast. So I'd like to open the door for that to be the case at some point.
Yeah, that's right.
Perhaps. But one of the things that really struck me about some of your research is the differences in recovery vital signs for sexual minorities, for mixed race, Native Americans, and that that the peer recovery support center might be an opportunity to actually create some more health equity, where we know very clearly from probably a lot of work that you have done and others that doesn't exist as well in the healthcare system. Can you just speak a little bit about that? And I think that could really be its own episode.
I would absolutely love to. Part of the emergence of the recovery science is now we are also measuring metrics such as quality of life, recovery capital, happiness, confidence. We care about those things as well as kind of bringing in the recovery movement. And now we track them. We track them as well to see how people are doing. There's the one thing about how everybody's doing in general, and then we don't want somebody left behind. And this is when we want to start to identify subpopulations who are not doing as well as other people. We know that in general, Okay, recovery science has told us that in general, for everybody, kind of when recovery starts out, we've got these recovery vital signs. Let's say we're tracking them up until about three. It's a very dynamic course, and we know that it's around 3 months or so. There's kind of this period of convalescence. It's a fire, it's a calm, the fire is out. This is kind of also how we've mastered detoxification. We've mastered kind of these ideas of putting the fire out. The question became about keeping the fire out. And this is what our recovery vitals show up to about 3 months. After that, it's almost like there might be a phase when the smoke clears out of the building, so to speak, and there's kind of a dawning of reality where you see what I have to clear up, what I have to make up, and this can be a distressing time. Those vital signs dip starting from about 3 months all the way around 3 months and hitting up to about a year and a half or so. People are feeling worse off during that time period than they were on day one. Now that we know that, we can plan for that. We don't want services that end up being pulled back at a year when we know course of illness, people are going to dip. The idea of these recovery support services now is, can you even prevent the dip or make the dip smaller than it would have been without the service? That can be a time of kind of this rude awakening. And after that, the climb starts. There's a climb that's going to start 2 years or so. It's going to keep going. And but it's a steep climb, around 1 to 5 years. This is that reconstruction time, we call it. The building materials are going to be needed. The permits to rebuild your life are going to be needed. And that's so people can make the climb that we see in the science. We see a climb happening about 1 to 5. So they start out, they dip down, go worse in terms of recovery vital signs. And then around 1 to 5 years, they're going to start the climb. The thing is, those trajectories, we don't want people left behind. We want recovery for all, right? That's why we look at subpopulations. And we want to know, for example, let's talk about primary substance. We know right off the bat that people with opioids and stimulant use disorders are starting worse off baseline. In terms of quality life and recovery capital, they are worse off than alcohol, and they are lower. Okay. And so we can know that now in terms of setting these agendas for who needs what when. That's where we're going with this. Additionally, we do know that sexual minorities are not doing as well. We can see that in the science. We've got a study out on that showing noticeable gaps, particularly with self-esteem going out to the 40-year horizon. And as well as differences regarding quality of life, happiness, and recovery capital throughout that whole horizon. Sexual minorities are not doing as well. They're not feeling as well. And we also have identified some racial groups that are not doing the same as their counterparts. We know that individuals who identified as mixed race and Native American are coming up on our profiles of these recovery vital signs as not doing, for example, happiness. They seem to be the same until about 2 years, then there's a drop, right? That's what mapping recovery vital signs and the recovery science can tell us, so we know what service for who, when, what intensity. That's how we build an effective infrastructure to address substance use disorders.
I love that, Dr. Corrie. That goes back to something that I've said for years, that there's no, one size fits all cookie cutter approach to recovery. What works for me may be different than works for someone else, and on and on and on. There's, of course, similarities that are true throughout. However, to really drill down and personalize the recovery experience, I just think that's phenomenal with the research that you've been spearheading.
Dr. Corrie, before we wrap up, for those who are listening, how do they find the research and the work that you're doing? Like, is there somewhere that folks can go online and see this work emerging and see what's been done so far?
Absolutely, sure. I'll tell you that a lot of our studies are available on PubMed. I referenced the National Recovery Study a couple of times. That was led by John Kelly. Corrie Vilsaint is also an author on that, Prevalence and Pathways. So I talked about that. We've also had a number of studies on recovery community centers. Again, primary author John Kelly, Corrie Vilsaint. I'm on some of those publications as well. and regarding recovery community centers. And so anybody's always welcome to email me at cvilsaint@mgh.harvard.edu. I always pass out our work. But a nice resource I want to turn people on to is recoveryanswers.org. This is a far more than a website. This is our contribution as scientists, public facing contribution, not go find the study and pay for it on PubMed. This is one of the largest repositories in the field, one of the largest of information. You need to go there. Anybody should be signed up for the bulletin. Okay, this is the easiest way to stay up to date with the science. We get the science, we rewrite it into a nice little one-page article. We do redo the graphs so that they're pretty and enjoyable, and we get to the punchline as quickly as possible. Fastest way to stay up to date in this field regarding, so you can see what's going on in the science and what questions are being asked. The dictionary is hugely popular. It's about language in the field and has just shot up. My goodness, people wanted a dictionary, it turns out. So go for the dictionary as well. And then if you're interested in learning about those recovery community centers, we've got seminars and an ongoing seminar series that we are doing on the website as well. So you should be on there. It's the easiest way to get up to date in this field. Thanks for asking.
Sign up for the bulletin when we get done with the podcast.
Excellent. That's right.
That was so fantastic. And I did mean it. I would love to have you back on. I feel like we could have talked research and treatment and recovery for days. So I think there's lots of opportunity for us to invite you back to Airing Addiction. But this has really been a gift for the first episode of 2024, which is a wonderful time for fresh start and fresh perspective. And I'm just really, really grateful to have had you on and to have met you and gotten to know some of the work that you are doing. So thank you so much for joining us. And James can make sure that all of those resources are in notes and things, so folks that are listening to the podcast might be able to find them pretty easily. But thank you so much.
Thank you. It's been an honor. Couldn't ask for better co-hosts. Thank you.
Thanks so much. All right, we'll see you all.